Hello, my name is Dallas Monet Kerr, and today's presentation will be about barriers to ED care African American women. Many African American women face the challenges of being overlooked in obesity, eating disorder care due to stigma, limited access, and biases. High prevalence, low detection. African American women had elevated rates of obesity and binge eating disorder bed, yet are frequently overlooked to eating disorder diagnosis. The reason is due to cultural and systematic barriers, provider bias, stigma, and a lack of cultural responsive care creates obstacles to proper diagnosis and treatments, which leads to overlapping health disparities. These challenges reflect broader racial disparities in both physical and mental health care outcomes, which reduces access and poorer outcomes. Ethnic disparities in the U.S. health system limits access, early detections, and ineffective treatments of eating disorder among racial minority groups, especially African American women. High obesity risk. Nearly 80% of African American women are overweight or obese, about a 50% higher risk than their white counterparts. Binge eating disorder prevalence. BED is the most common eating disorder among Black Americans, with a lifespan prevalence of 0.62 to 1.48%. Undiagnosed despite needs. Although eating disorder rate among BIPOC individuals match or exceed those of white population, only about 20% those affected receive treatment. Comorbidity and mental health burdens. Individuals with eating disorder often experience up to 80% chance more of mood swings and 59% of anxiety, and only 23% of them reporting attempted suicide. Obesity, eating disorder, underdiagnosis among African American women in the U.S., high prevalence of obesity and binge eating. African American have one of the highest obesity rate. Binge eating disorder bed occurs at a similar or higher rate compared to the white woman. So 5% versus 2.5% rising, which is 30% among obese black women. Unique drivers of disorder eating, stress, trauma, discrimination, food security. Strong Black women norms contribute to ED as coping mechanisms and not just weight concerns. Under recognition of bias in clinical settings, clin- um, clinics often assume ED only affect thin white women, leading to dismissal of symptoms in Black women. Focus on obese-related health rather than exploring ED system. Diagnose hurdles due to weight stigma, BMI limitation. Medical providers prioritize BMI or stereotype healthy weight models, overlook ED with higher BMI. Social stigma around obesity reduces care seeking and recognition of ED. Barriers to accessing and restaining treatment. Black women with bed are significantly less likely to seek treatment and more likely to drop out. Cultural stigma and lack of cultural competent care further hinders help seeking. Cultural misconception and diagnosed bias. Many healthcare providers misidentify ED only affecting white thin women, leading to misdiagnosis or non-diagnosis for African American women, especially those with higher BMI. Weight stigma overshadowing ED systems. Providers can often focus solely on obesity related risk, hypertension, diabetes, ignoring disorder eating behaviors, especially binge eating, that coexist with obesity. Underutilized of mental health resources. African Americans face historical mistrust, cultural stigma, and lack of cultural responsive care, resulting in lower treatment seeking and retention rates for ED. Why this matters? Addressing the overlap of obesity and ED. Black women with obesity are less likely to be diagnosed with ED, even though they often report binge eating. The right screening and provider awareness can close this gap. Reducing stigma leads to better engagement. Weight loss stigma in healthcare discourage access and cultural sensitive practice and foster better provider patient dialogue and outcomes. Bridging resources and practice gaps. These are a critical underrepresentation and risk research for Black women. International adaptation will ensure intervention is relevant and effective. And the goal is to improve diagnosis and treatment access to obesity and eating disorders among African American women in the U.S. For the key objectives, increase awareness and cultural compensity. Provide training for providers of bias stigma and cultural sensitive care. Promote public health campaigns that reflect diverse body types and eating disorders experience. Expand access to care. Support community based treatment options and affordable care models. Partner up with local organizations and HBCUs to underserved population. Improve early screening and identification. Integrate screening tools in primary care setting, especially underserved communities. Encourage providers to screen beyond stereotypical eating disorder profiles. Strengthen community and peer support. Develop a mentorship and support group tailored for Black women. Host community events to foster dialogue and reduce stigma. Behavioral goals. Increased diagnosis rates of bed, either ED in African American women. Improved treatments and mental health outcomes through cultural component care, and reduce stigma in seeking help for ED in Black communities. And here is my research. Thank you again for letting me to present, and I hope you learn something about ED when it comes to African American women, and I hope we can make a difference. We can build a strong relationship and a supportive community. Thank you again.